Welcome to CHDWise, an educational series where Conquering CHD partners with hospitals across the United States to talk about important topics to patients and families. This month's topic will be diving into cardiac health and fitness. In collaboration with Children's Colorado, we are excited to have three leading experts in the field. First up, we will hear from Elizabeth Jung, who is an associate professor of cardiology in the Department of Pediatrics at the University of Colorado School of Medicine. She specializes in adult congenital heart disease and practices at Children's Hospital Colorado and University of Colorado Hospital. She is the director of the Teen Transition and Readiness Program. In addition to pediatric to adult transition care, her clinical interests include the treatment of lipid disorders in children.
Thank you so much for allowing me to be here. I look forward to spending a little bit of time explaining what I do and how it can help you. So my portion of the webinar is to talk about preventative cardiology. So first off, we need to define what we mean by preventative cardiology. Well, we're talking about things that we can prevent, so heart disease that we can stop from happening in the future. But heart disease as a term is vast. It's kind of like when we talk about apples, right? So everybody knows what an apple is. You could describe it. Most of us have probably had hundreds of apples in our lifetime. But did you know that there are over 7,500 apple varieties that are grown worldwide? I'm pretty sure I've had, well, I thought I only had about 10, but when I looked at the list, I had probably about 20 of them. But, when we bring that back to heart disease, it's like there's so many different types, and what is it that we're actually talking about? So you're probably most familiar with congenital heart disease, the type that you're born with. Sorry. And then there's ischemic heart disease, say from coronary disease like plaque, that can cause heart attacks and strokes. And then there's a whole mixed bag of diseases due to like hypertension, inflammatory conditions, and other systemic diseases. And so preventative cardiology focuses on trying to prevent events like heart attacks and strokes. You may be wondering, well, what about congenital heart disease? As the #1 most common congenital heart defect, there's ongoing research looking at the genes that might be involved. But as you know, life is complex, and we certainly don't have the answers explaining all of congenital heart disease. And so before we move on, I really do want to acknowledge the tremendous amount of progress that has been made in surgical and technical advancements to treat congenital heart disease. But when we go back to heart disease, we really don't want to compare oranges to apples. But as we know, even apples to apples can be difficult. So why am I harping so much on preventative cardiology? Well, this is the US mortality data statistics for the 2020-2021 year. It really hasn't changed a lot over the last 20 years, for the exception of COVID over the last few years. And the top three reasons for US mortality have been heart disease, cancer, motor vehicle accidents, and then more temporarily COVID. But when we take a closer look at heart disease, we see this. So this is actually the breakdown from the last analysis in 2001, but the big picture is really the same. The majority of cardiovascular disease deaths are from coronary heart disease, otherwise termed acquired heart disease, which we consider to be preventable coronary disease. Congenital heart defects, however, only constituted 0.4% of that big wheel. So overall, that's great news for people who have congenital heart disease. But the bad news is that we're all susceptible to acquired heart disease. And so that's why we put a lot of focus on that. So what can we do to prevent acquired heart disease? So this is Life's Essential 8s from the American Heart Association. I'd suggest taking a look at their website when you have some time. They have a lot of really great information. And so these are 8 things that you can improve or factor in to your cardiovascular risk. So let's take a closer look at those. The first one is eat better. So simple, right? We all know we can do better, and most of us have a pretty good idea of what's obviously bad for us when we're choosing our foods. But there's so many diets out there, so much information, but also a lot of misinformation. Honestly, I would say that most of those diets out there have some element of being right, but most of them are temporary they're unsustainable, and perhaps even dangerous to people with chronic heart disease. So when I counsel patients on dietary changes, I really recommend making 2 to 3 specific goals and then gradually building on that. And I would say I never expect anybody to make a complete 180 overnight. You cannot just completely change your diet and expect that to stick. And we really want people to consider it a lifestyle adjustment and not something that's just temporary. And then also for everybody to remember that everyone has setbacks, and a setback shouldn't keep us from trying to keep moving forward. And then the last thing to remember with this is that there are really some great nutritionists out there who can really help you if you get stuck. Number 2 is be more active. So Dr. Jacobson is talking about exercise, so I won't go into this too much. But just as a reminder, the recommendations are for at least 150 minutes of moderate to vigorous activity per week for adults and an hour daily for children. But moving on to the next one, which is quit tobacco. We all know the association of nicotine and lung cancer, as well as oral and gastric cancers too. But smoking is the #1 preventable cause of death in the United States. 1/3 of the deaths due to coronary artery disease are actually related to smoking and secondhand smoke exposure. And in the past few years, besides cigarette smoking, vaping has actually become extremely popular, particularly in teenagers and young adults. However, vaping has been associated with severe lung injury, still exposes you to the dangers of nicotine, and is not a better alternative to smoking. The toxic chemicals found in both tobacco as well as vaping aerosols include nicotine. There are ultrafine particles that can be inhaled deep into your lungs, causing damage. Some of the flavorings, such as diacetyl, it's a chemical that's linked to severe lung disease. There's volatile organic compounds and cancer-causing chemicals, not to mention the heavy metals such as nickel, tin, and lead. And then another scary statistic is that half of the children in the United States aged 3 to 11 are exposed to secondhand smoke or vapors. So this is definitely one that you would want to take a closer look at. Okay, moving on to sleep. So get your sleep, right? 7 to 9 hours of sleep per night is recommended for adults, more for younger people. Sleeping really helps heal the body. It aids in healing, repairing your cells, tissue, and blood vessels. And poor sleep puts one at risk for cardiovascular disease. Sleep can also result in a stronger immune system, better mood, helps you fight against depression, and creates better brain functioning with improved alertness, better decision-making, focus, and memory. And conversely, poor sleep can also put you at risk for obesity, hypertension, and diabetes. The next one takes a look at maintaining your weight, and maintaining a healthy weight is really an important part of preventing cardiovascular disease. So an ideal BMI is about 25. The formula is your weight in kilograms divided by your height in meters squared. It's pretty easy to find an online BMI calculator, so I'd recommend everybody kind of go out just to kind of see where you're at. And the reason why we worry about it is that excess weight puts it a lot of additional strain on the body's organs, and the association of additional weight with illnesses like diabetes, hypertension, and metabolic disease. And all of this adds to that bucket of risk factors, which increases your risk for cardiovascular disease. So let's take a slightly closer look at that. So the first one is diabetes. It's pretty prevalent in the United States. There are 2 different types to be aware of, type 1 and type 2. Type 1 is typically diagnosed in childhood, usually due to an autoimmune process attacking your pancreas. And in that effect, you don't make enough insulin. Type 2 is a little bit different, where it's typically diagnosed in adulthood and due to insulin resistance. And the way that this works is that the insulin takes glucose up from the blood and then brings it into the cells to be used as energy. So over time, if you have diabetes, the body can't use the insulin it makes efficiently, and then also eventually makes less insulin. And then the result is that you have a high blood glucose. In general, too, blood glucose rises from dietary intake of carbohydrates and sugars. So if you are diagnosed with diabetes, it's really important to monitor your blood sugars regularly, as this puts you at increased risk of heart disease and stroke. And in trying to prevent diabetes, really monitoring our dietary intake of the carbohydrates and sugars is very important as well as exercise. When we take a look at blood pressure, right, everybody should be getting their blood pressure checked at their annual doctor's visits, as well as every time you see a medical provider. High blood pressure can lead to cardiovascular disease like strokes and heart attacks. And the way this works is that long-standing high pressure causes those blood vessels to become stiff, and that results in less blood flow and oxygen to your organs. So exercise and dietary modifications that we've been talking about are really essential for maintaining a normal blood pressure, but taking your prescribed medications are of utmost importance once you actually are diagnosed. And then lastly, to just be aware that, if you're monitoring your blood pressure at home, if you have numbers higher than 180/20, we consider it a hypertensive emergency, and really important that you contact your doctor immediately. And then lastly, we're going to take a look at cholesterol. So we all know that high cholesterol leads to heart attacks. And yes, it is one of the major risk factors for cardiac events. But again, it's all about the number of risk factors. So the more risk factors you have, the more likely something is to happen. So I just don't want people to always feel like just because they only have high cholesterol, that automatically means that they're going to have a heart attack or stroke. And that's not necessarily the case. Screening should begin in childhood as early as age 9, sooner if there is a strong family history of high cholesterol. And this screening should continue into adult life, getting checked every few years at a minimum. There are some people with genetic causes of high cholesterol with a major defect in one of the 4 main genes. These people will easily have an LDL cholesterol above 190, and it may actually be impossible to control their cholesterol with diet and exercise, but most of us don't actually have that. But rather we have a complex interplay of genes and environment where our cholesterol can be elevated, but luckily modifiable with diet and exercise. And so the general rule of thumb in these situations is when trying to improve our LDL cholesterol is to limit foods high in saturated fats. So typically these are going to be our animal fats, fatty dairy products, fried foods, and also limiting our egg yolks while trying to increase our dietary fiber. Another component that you'll come across is called a HDL. So a low HDL, which is actually the good cholesterol, so you want this number to be as high as possible, can also be a risk factor, but a little bit less so than the LDL cholesterol. So exercise and foods with good fat, so think like omegas, like salmon, nuts, avocados, these can really improve the HDL cholesterol. And then lastly, triglycerides is another component that can be a risk factor, but again, often more related to metabolic syndromes such as like obesity and diabetes mellitus. This is elevated when your body can't process all the sugars you take in and end up circulating in your bloodstream longer than it should. And again, exercise, omegas, and cutting down your sugar and carbohydrate intake is the best way to improve this number. So hopefully you found some of this information. I know we went through it pretty quickly, but maybe just enough to give you a glimpse into something that maybe you want to do a little bit more research on your own or ask your doctor some additional questions. Just like to remind you that there's no time like the present. Oftentimes we put these things off, but any movement that we make towards improving our lifestyle will ultimately result in our better health long term. So thank you for listening and thank you for your time.
Next up, we'll hear from Ronnie Jacobson, who is an associate professor of cardiology in the Department of Pediatrics and Internal Medicine at the University of Colorado School of Medicine. She specializes in adult congenital heart disease and practices at University of Colorado Hospital and Children's Hospital Colorado, where she also serves as the associate director of the ACHD program. Her clinical and research interests include exercise and physical activity in patients with congenital heart disease, as well as helping patients transform from pediatric to adult care.
My name's Ronnie Jacobson. I work at Children's Hospital of Colorado, primarily in pediatric and adult congenital heart disease, and then have a special interest in physical activity and exercise within this population. So today we're going to talk about physical activity and exercise in congenital heart disease. I do not have any disclosures, but as you can see from my little playset here, I do like exercise. The objectives of this talk is we're going to talk about physical inactivity and exercise intolerance in the congenital heart disease population. We'll then talk about what is the difference between physical activity versus physical exercise. What are the limitations of training programs that we currently have for congenital heart disease? What are the benefits of some home-based programs that have been developed? What are ongoing challenges that we face? And then what do we have to look forward to in the future? So first, let's talk about exercise intolerance and physical activity in congenital heart disease. We know that patients often overestimate their physical capabilities and underreport their limitations as they've been living with them their whole life, so really don't notice a change over time. This is because they've maybe never have experienced what normal function really is. And we know that in the congenital heart population at all ages, that everyone experiences exercise intolerance, and this has now been associated with an increased risk for hospitalization and death. We know that when they do experience this limitation in exercise, that it seems to be not just when we're pushing ourselves like on the treadmill, but also at levels that we would normally be doing day to day. And although everyone hates it, it seems that cardiopulmonary stress testing has become a vital tool in our population. It provides information on how the heart is functioning and also as well as other causes of symptoms that patients may be experiencing that aren't related to the heart, but might be related to their muscles or their bones or even their lung function. And that we also know that the data we get from a stress test can help us make decisions about whether patients should be undergoing interventions or surgery and even prognosis, how they will do. And now, more importantly, we can use this information to help build and guide activity and exercise prescriptions. So just to highlight what I talked about, this is sort of an older graph that on the left side demonstrates your type of congenital heart disease. And on the top, it talks about severely impaired to normal. And this is what we predict on how patients will do on an exercise stress test. And as I said, we know all patients with congenital heart disease perform at a little bit lower level compared to their peers, but hopefully this is changing. So what contributes to this decreased exercise tolerance in patients with congenital heart disease? And this seems to be multifactorial, one related to some of the plumbing or heart function, some related to the electrical system of the heart, but a lot of it is still and continues to be related to not only patients and parents, but also provider and society beliefs about what is safe and not safe. And oftentimes we have leaned more towards restrictions with physical activity instead of promotion of physical activity, to the point that the CDC recently demonstrated that 86% of patients with some sort of chronic long-term health disease are limited from participating in activities at schools. So we also know that physical inactivity is a global crisis. None of us are as active as we really should be. And this inactivity, when starting at an early age, can also impact motor development and overall quality of life. And we also know that not just patients with congenital heart disease or the general population, but when we look at all of them, patients with congenital heart disease are less physically active compared to their healthy peers, and that they're also at increased risk for acquired heart disease. We know that cardiovascular risk factors seem to be increased in patients with congenital heart disease, and that 80% of all young adults with congenital heart disease have at least one cardiovascular risk factor, and that a sedentary lifestyle at least doubles the risk of serious disease and premature death. But there is some promising things. Patients with congenital heart disease who are fairly active have positively correlated their level of daily activity with their exercise capacity. Exercise and physical activity in this population seems to improve health and all-cause mortality. There seems to be benefit from just participation at a moderate intensity, so not just pushing ourselves all the time. And that simple physical activity interventions in this population seem to be feasible, meaning we can do them safe and have shown improvements in our exercise tolerance, but not only from a heart health standpoint, but also an improvement in mental health, particularly as it relates to quality of life. So preventative and/or intervention through physical activity should begin as early as possible in childhood, it seems from what we know, to instill lifestyle changes and improve overall cardiovascular health as our patients get older. So despite what we do know, though, there is still evidence, despite the evidence linking sort of a lower functional capacity to poor outcomes and that exercise seems to be safe and beneficial, a lot of patients with congenital heart disease remain inactive. And this is multifactorial, again, based off of fears, but also some of it falls on the providers and helping to educate not only patients and families, but also helping to provide more information and guidelines to practitioners about how to help our patients be more active. So what is the difference between physical activity and exercise? Physical activity is any bodily movement where we increase the amount of energy we need from what we're doing when we're just sitting there on the couch. And this can be a habit, it can be a part of daily living, or it can even be part of a structured program which we have gotten into. Versus physical exercise, which is a subset of physical activity. This is planned, this is structured, and this is repetitive, meaning we do this very consistently. And there's usually sort of an objective. We're doing this because we want to stay in good shape, or because we want to get better, or we want to join the softball team or play co-ed soccer. There's usually a goal with physical exercise. So what do we know about the guidelines? Well, in 2018, for all Americans, we said that aerobic physical activities such as running or biking for adults in accumulated sessions, meaning you didn't have to do 30 minutes of continuous exercise, but if you did something for 10 minutes and you did it 3 times over the course of the day, that would count. And that the total volume of the moderate or vigorous physical activity was related to health benefits, and this prescribed duration was not necessarily essential, as I talked about. And that sufficient physical activity was defined as at least 150 minutes of moderate intensity activity and 2 days of muscle strengthening per week for adults, versus in kids and adolescents, they recommended at least 60 minutes of moderate intensity activity and 3 days per week of muscle strengthening. So we've moved from just talking about going for a run or riding the bike to also incorporating improving our muscle strength. So what about specifically in patients with congenital heart disease? Well, the American Heart Association says that physical exercise has many benefits and should be a regular part of almost everyone's life, including most people with congenital heart disease. That research on patients has shown that moderate exercise is safe and can be beneficial, and that for most, the benefits of exercise outweigh the perceived risks. So that despite all of this taking into account, they still said, well, probably low intensity activity would be preferred for most people. Well, in 2020, the World Health Organization also released more recent physical activity guidelines, particularly in children and adolescents 5 to 17 years old. They were saying that you should average at least 60 minutes per day across the course of the week of moderate to vigorous activity. That vigorous activity includes bone and muscle strengthening 3 times a week, in addition to sort of getting your heart rate up, and that we should minimize sedentary activities. So that's sort of physical activity, but when we go and look at the literature about what they say regarding what we should be telling our patients with congenital heart disease, the majority of recommendations out there talk about participation in sports or more competitive activities. So this is just an example based off of your type of congenital heart disease on the clear left, what we would say you should or shouldn't do. And this was the more recent publication, which again, if you look at the left, that sort of talks about muscle strengthening or how much you could increase that, versus on the right, talking about increasing your heart rate. But again, we're sort of talking more about physical activity now instead of competitive sports like participating in a decathlon or cricket. So is this really realistic for our population? So what do we know about exercise programs and the limitations in congenital heart disease? So training programs in congenital heart disease, so exercise interventions, whether it's just we tell you sort of something to do versus your actual participation in cardiac rehab, seem to be safe, again, feasible, and there are improvements in functional outcomes, such as your exercise capacity, how much physical activity you participate in, your overall self-perception of how you feel, life satisfaction, and general health. But a lot of this is not that the patients are not willing to participate in exercise, but they're not certain of what is safe or beneficial. And I would say this also goes on to providers as well. Again, though, moderate intensity exercise seems to be what our patients need to do for the health benefit. And there are an increasing number of studies in training programs for patients with congenital heart disease, but a lot of them remain hospital-based and supervised, again, for concern of perceived fear. So this is sort of translated into more home-based training programs because this could reach a broader range of patients and provide more flexibility and convenience. The patient preference is taken into consideration, such as their goals and type of activity and what they're able to do, as long as their goals meet what sort of the recommendations are per the guidelines. It seems to enhance self-efficacy and improve participation, and that these commercial activity trackers, like Dr. Nash was talking about, seem to be promising for measuring, prescribing, and promoting activity in our patients. Although, again, there's some reliability and validity questions that remain in our population. And then that these lifestyle, again, and behavioral changes, not just while you're in the program, but building activity more as a regular part of your life, seems to have a much higher degree of sustainability and self-monitoring. But there are limitations. There still continues to be decreased adherence, a lot due to inaccessibility or inconvenience in our patient population. There is a lot of reliance on patients and on us for family members to help figure out how to incorporate these programs, whether they're supervised programs or home-based programs, and finances and logistics of it. There is a cost to any sort of program, and there's a lack of reimbursement by insurance companies in patients with congenital heart disease. Oftentimes, motivation is an issue, time is an issue, and a lot of patients don't enjoy exercising. So we need to understand how to help them find this to be more satisfying. There's not a lot of options for some patients, and so they can get bored if there's not varying exercise types or how often we're telling them to do something. And so with all of this in mind, there's ongoing challenges. Even though programs have been developed in patients with congenital heart disease, they seem to be underutilized, again, with variable adherence. We don't really know what type or how much exercise we should be doing for our patients with congenital heart disease. How do we measure this? Is it just measured by their success and how they feel and a lifestyle change? What's the best way to communicate with them and monitor their participation and continue to motivate them? And what do we know about wearable monitors, and how can this be helpful in this population? And again, a big one is reimbursement, not only for actual participation in the program, but what about the providers? They also need time and resources and specific knowledge to be able to guide our patients. So what has been developed in congenital heart disease? These are just a few examples I'll run through quickly, but this was a publication that said, if your patient wants to exercise, these are all the things you should take into account. How's their heart function? What are the pressures in their lungs? What is the size of their blood vessels? Do they have abnormal heart rhythms? What's their oxygen saturation? And sort of taking all of those into account, you either fall into green, orange, or red, and then that should tell you how much you should exercise based off of how you did on your stress test. But again, a lot of this is around sports and competitive activity. A more recent publication, again, is sort of taking these same things into factors when we're talking about exercise and the information we can get from a stress test. And also now more specifically an individualized approach with what the specific diagnosis is for congenital heart disease. Do they have a pacemaker? Would muscle training be helpful? Have they done cardiac rehab? That then gets us clear to the right, where I think is really where we're headed, that most of our patients should have an individualized program, whether this is home-based or supervised, and what we should be using more as the type of exercise. Like I said, should we be using heart rate goals, although a lot of our patients don't have normal heart rate response to exercise? Should it be high intensity training? Should it be a combination of running and jogging and weightlifting? And I think this is where we still have more work to do. So I sort of take it as exercise needs to be a habit, and this should be the initial focus. And what we ask our patients to do really needs to match what their interest is and what they have the ability to do, as a lot of patients don't have the skills to be able to exercise like we would expect. And we should have an assessment. Do they want to exercise? Do they want to change their behavior? what is important to them from a physical activity standpoint, and then taking all of this together with what we know about their congenital heart disease and prescriptions to help set them up for success. That they should probably do a minimum of 30 minutes of moderate intensity activity at least 5 days a week, or a minimum of 25 of more vigorous activity at least 3 days a week, or they could do a combination of the above, and then again, including building muscle strength as well. So what we know is that if patients, whether they have congenital heart disease or not, if it is intrinsic motivation, meaning they're wanting to get out there and do this, they usually do about 40 to 60% of what we would expect to be max, where we're really pushing ourselves to avoid fatigue. In fitness training, where you really have that goal, again, physical activity versus physical exercise, is more of the 60-80% of what your max would be when you're really pushing yourself. So in general, I think a threshold-based prescription has a much better impact than a range-based. And again, this goes back, what should we be using as our parameter? Should we be telling our patients heart rate? Should we just be telling them a duration? Should we tell them do what you feel good doing? I think that's, again, just a question we have out there. But I think the future is very hopeful in congenital heart disease. So if we sort of move from left to right, we've gone from a very sort of when I was training to restriction of physical activity to now incorporation of physical activity of programs where we were promoting physical activity and telling our patients to be active. And we've now sort of moved more towards exercise training where we think planned, structured, repetitive movement is helpful for physical fitness, and really focusing on cardiac fitness, not just saying go out and do these things, but an interdisciplinary approach, not just going to exercise, here's your prescription, but what can we teach you about nutrition and diet? How can we help your mental health with psychosocial counseling? Having physical therapy and occupational therapy involved to help our patients be able to do the things that they want and do them successfully. So my takeaway points are that physical inactivity and exercise tolerance are common in patients with congenital heart disease, that discussions and implementation of regular exercise and physical activity should be a routine part of our care, with a focus on the patient's readiness to change, meaning exercise is just as important as some of the medications we're prescribing. And although there are increasing numbers of exercise training programs in congenital heart disease, a lot of them still remain hospital-based and supervised, again, because of perceived risks and fear. But home-based programs seem to be safe, feasible, and beneficial, although with ongoing challenges, and that there are ongoing efforts to improve understanding and provide guidance in how to counsel and establish exercise and physical activity programs for our patients at home and at school and in the community, with a goal of long-term change in behavior and lifestyle, which really needs to be individualized. Thank you.
And last, we'll be hearing from Dustin Nash, who is an associate professor of cardiology in the Department of Pediatrics at the University of Colorado School of Medicine. He specializes in pediatric electrophysiology and practices at Children's Hospital Colorado. Some of Dr. Nash's recent research experience centers around the diagnostic performance of the Apple Watch and cardiac features in pediatric patients and the impact of device miniaturization in the pediatric population.
Thank you to Ronnie and Liz for both of those great talks. I am excited to wrap things up here. I have an interesting topic I wanted to talk about, one that actually comes up quite a bit, both among kids with congenital heart disease and just kids with without congenital heart differences. And so the title of my talk is specifically, "But My Apple Watch Said." And the topic we're going to discuss is wearable data in pediatric patients. And so in terms of background, let's talk a little bit, first of all, about what wearable technologies exactly are. If we turn to Wikipedia for a definition, we would learn that wearable technologies are really, electronic devices or mechanical devices that are worn close to or right on the skin, where they can sort of, detect body signals, vital signs, other information, and provide that as immediate feedback to whoever is wearing them. And, we talk about it like it's a relatively new thing, but wearables have been around for a while. So on the left is the Nuremberg egg. This was in the year 1550. This was the first pocket watch which was invented. It allowed people to sort of carry a clock with them. All the way up to 1975, the classic calculator watch. This was the first release when someone could actually, calculate the tip on their own wrist. And then, finally, what we have over here on the right is a big list and a big, demonstration of all the different options we have on the market today. Tons and tons of devices which can provide all sorts of information to us at the drop of the hat. And we've reached this interesting time. So it used to be that, 15, 20 years ago, it was very clear, we would say, this is a Holter monitor. This follows under the umbrella of a medical device. This is an iPod. This is definitely a consumer electronic. There's no health application here. But with the new wearables, it's hard to say exactly which umbrella they fall under because, they definitely have consumer electronic features, and that's mostly what it's marketed towards. But it is recording vital signs. You can record EKGs on an Apple Watch. And so it has features of a medical device. And that brings a lot of power. It brings a lot of information. It also brings a lot of questions. For instance, somebody's Apple Watch may beep off to let them know that overnight their heart rate was too slow. Some parents will have an Owlet monitor that they keep on their baby, and they may say that my Owlet monitor is beeping off, but my baby seems fine. Or you get a reading from your Fitbit that tells you that your heart rate variability is low. What exactly do these things mean? And really the question is, among all these different wearable data, should we trust it? Is the information that we get from an Apple Watch equivalent to a medical test? Is it equivalent to a medical device? And so I want to delve into a couple examples. This is, of course, not going to describe every example of a wearable technology that's out on the market, but just a little bit of background information on the Owlet sock, how it works, what you can trust and can't trust from it, and in the same topic for the Apple Watch, to really get into like the nitty gritty in the background about what we can believe from the information coming from these devices. So let's talk first of all about what the Owlet Smart Sock is. So this is something that came out within the last 10 years, and it was really marketed towards parents with healthy children at home and something to give them peace of mind. It is a pulse oximeter embedded sock that would allow them to monitor their baby, basically while they're sleeping. It can record pulse ox and heart rate, and that information is available on demand. And it spits out these really nice graphs, right, where you can look back over the last day or so to say, what was my baby's pulse ox? What was my baby's heart rate? Where are they sitting right now? And this all seems like really valuable information, and was marketed as such, as sort of like something to provide peace of mind. It starts to be interesting when you dive into some of the information about how they determined whether the Owlet sock was actually accurate. You look at the first study. This wasn't actually even published, but it was information that they had to provide to the FDA. And they took 10 participants who were of age 18 to 65 years old, with a mean weight of 160 pounds. So you can already tell those numbers differ drastically from what they were marketing it towards. And what they did is they measured from blood draws what the level of the oxygen was and compared it to what they were getting from the Owlet sock sensor, and sort of showed that it was within reliable standards. Then they moved on to say, well, maybe we should probably look at kids as well, and they looked at 15 kids that had normal vital signs from the ages 0 to 17 months. And compared it to a hospital grade pulse oximeter and sort of asked the question, was there a big difference between these? And they said they didn't actually provide all the information. They said this reaches desired industry accuracy standards. And with that information, the sock went onto the market. And as you can see, it wasn't a super robust validation. They didn't really, push the sock to the limits to try to say, how does it perform when vital signs are abnormal? Or for instance, when a kid has congenital heart disease. Some people made some token effort towards that. This was a research letter that came out in JAMA in 2018, where they sort of asked the similar questions to say, like, well, how accurate are these compared to pulse ox in the hospital? And they showed that like the sock was pretty good. These can be kind of confusing graphs, but I'll summarize it. Basically, the sign on the graph on the left says that the sock was pretty good about picking up when heart rates were too slow. And the one on the right said the sock was okay at sort of detecting a pulse oximeter reading, but that sometimes it missed. There were kids whose oxygen was actually low and it did not detect. And so all that to say, this was October of 2021, after this device had been on the market for 5 or 6 years at this point. The FDA sent a warning letter to the company that made the Owlet and basically said, look, you're marketing this as a medical device. You never sought FDA approval. Like you're going to need to pull this off the market. So they made some drastic changes to the device, and they've done more testing, the data of which actually has yet to be released, but it's back on the market now, and they have both a prescription version and just an over-the-counter version that's meant sort of to be used with normal babies. I don't actually have all the information and all the data to say what this was used for or what was used to validate it to this level, but they do have an FDA approval now. And so the takeaways from the Owlet sock, it's usually reliable, but it's not infallible. There will be false positives, meaning that the baby's vital signs may actually be normal, but the sock is alarming. And there could also be false negatives where the vital signs are actually abnormal, but the baby is or the Owlet is reading as normal. But it does seem to be better than the comparators that are out there. And all technology is going to have their limit. It's just important to know that it's not perfect. It has sort of shown that it can capture extreme heart rates. They did this in one study, but it hasn't really been validated to say, can it capture every episode of high heartbeats? And they have one study that they looked at to ask, people who came in specifically because their Owlet went off into the ED, what did they find? And in the vast, vast majority of cases, it was non-serious conditions or the babies were actually totally normal. All to raise the question, is this an expensive peace of mind, not just with the $299 price tag, but with the ED copay and everything that it may cause? So let's talk about another prototypical example of a wearable technology. So this is the Apple Watch. As we know, the Apple Watch is sort of like surging in popularity, and it's been increasing in both availability, and it's also being marketed more and more towards teens and children. So this is an alternative to a cell phone, is sort of as it's pitched. And so coming along with any Apple Watch, you're going to have some health features. So there's heart rate monitoring. It does this by reflective photoplethysmography. So that's a little green light that shines on the back of the watch. And basically what happens is based on how much light goes into the skin and then bounces back, it's able to detect how often blood is flowing through the skin with the heartbeat. And based on that, you can calculate a heart rate. In their studies, or in the documentation provided with the Apple Watch, they said this is accurate between a range of 30 beats per minute to 210 beats per minute. And the data can be viewed as both individual values and graphic trends. But another big marketing feature that they show is that the Apple Watch can record an EKG. So this is the same electrical data that is recorded on an EKG or an ECG when you go to a clinic and have an ECG done, with the exception that it's only on one lead. It's similar in many ways to the data that's recorded on a Holter monitor or a patch monitor that you may get from your doctor. But we come up with the same question, is like, can I trust the data? People have looked at this more extensively in adult patients, including one large publication where they sort of said that, the Apple Watch at detecting atrial fibrillation in adults is pretty good. However, we know that adults are not the same as kids, and there may be limitations to kids, and that's all over inside Apple Watch's documentation, where they say, this is only approved. It's only the Apple Watch ECG app has an FDA indication for patient or for wearers over the age of 22, and there's no documentation about whether they check to see if the heart rates were accurate. And so this was actually something that my several investigators and myself sort of looked into. And so we put the Apple Watch on all sorts of people. We put it on patients who were in the hospital when they were, also on hospital monitors. Patients who were undergoing EP studies and patients who were undergoing exercise tests. And we were also able to record EKGs. And yes, it's not that easy, but you can use an Apple Watch to record an ECG on your baby or your small child if you're ever interested. Feel free to reach out to me if you really want to know the nitty-gritty about how. But we were able to record all sorts of interesting rhythms, arrhythmias that we saw in the hospital, including supraventricular tachycardia, ventricular tachycardia, and atrial flutter, like we see on these EKGs here. So to delve a little bit more, we should ask the question about how accurate was the Apple Watch heart rate measurements in our study. And so once again, this is kind of be an overwhelming graph, but needless to say that among all of our measurements, we had over 1,000 measurements that we painstakingly measured both on the Apple Watch as well as from the hospital grade monitor. We saw that, it was pretty good, but not perfect. Over here on this graph, if everything would have fallen along this line, we would have said, this is a really good monitor. And over here, if everything would have been flat, we would have said, this is also a really good monitor. But you notice there's some missing points that sort of fell off the line here. And what we saw when we separated it out was that, in fact, those patients who are having arrhythmias, or i.e., if you were in an abnormal heart rhythm, when the Apple Watch was trying to measure your heart rate, it wasn't as accurate. It really tended to underestimate it. And there's reasons for this. In fact, the same reason you had symptoms in an abnormal heart rhythm, the pulse probably isn't as strong, and that was affecting the Apple Watch's ability to count your heart rate. So all that to say, of the 80 patients we had in our study, there was excellent agreement really in normal heart rate ranges, as long as it was in a normal rhythm. But heart rate measurements in arrhythmias were really unreliable. The EKG data was quite good, specifically in the ability to say, is this a normal or an abnormal heart rhythm? And definitely seemed to be of a higher value than just the heart rate data alone. So sort of in summary, we're trying to answer this question, do you trust the data? And I really have to say, my opinion is it sort of depends on the situation and the context to which you're provided. So do you trust the data? In normal ranges, the Owlet sock seems to be pretty good when compared to a pulse oximeter and its ability to provide a heart rate and an oxygen saturation. And all that as a caveat, it's really designed to work within normal ranges. Patients with hypoplastic left heart syndrome who are, in that first stage of repair, it has not been tested on them to say really how accurate is this. Patients who are having supraventricular tachycardia or other patients with congenital heart disease, we don't necessarily know exactly how the Owlet is going to function in these patients. And in terms of the Apple Watch, I would say, the Apple Watch is not equivalent to a Holter monitor, and they shouldn't be thought of as the same. It can provide valuable information. In the right context, you can provide reassurance based on some of the heart rate measurements, and the ECG data can be useful at providing a diagnosis. But once again, it's not going to be necessarily slam dunk, if that makes sense. It's not going to be one for one. So as an overall summary, what I would say is that for wearable data in pediatrics, that wearables often function well within normal vital sign ranges, and that can be a source of reassurance. If you're getting normal values, you can mostly feel reassured. However, consumer technologies like the Apple Watch or the Owlet are rarely validated at clinical extremes, meaning that, really abnormal vital signs like we see with very sick patients in the hospital aren't going to be able to be confirmed using these consumer technologies. And so you may have false negatives or false positives with a higher frequency outside of those normal ranges. And finally, clinical diagnoses can be made with the data, and it can be helpful things to provide to your physician, but you're not necessarily going to know if you are missing everything, if that makes sense. These aren't perfect, and definitely aren't going to take the place of all the hospital grade monitors and technologies that we have. So if you have any questions, here's my email. You're more than welcome to reach out to me. I'm happy to discuss more at length, including if you just want to know how to do an Apple Watch on your baby. And that's all my slides. Thank you.